Sorry for that. Thanks for your patience, Dr. Perry.
Sure, no problem. Seems to be our day for technical issues. If it's not on our side here, it's on your side, but we'll keep going.
Sure.
So I think we lost connection somewhere around the pilocytic astrocytoma component. Basically these are in kids and young adults mostly, and cerebellum is the most common location, optic pathway, spinal cord. So here's an example. They often have this cyst with a mural enhancing nodule imaging appearance, as you see here, which is very different than the diffuse gliomas. And this can be extremely helpful on a small biopsy when you're not sure if it's a diffuse astro or a pilocytic astrocytoma. Now, pilocytic astrocytoma is literally a hair-like cell, pilocytic. Pilo is hair. And we can see these long hair-like processes best usually on a smear, an intraoperative smear. Unlike the diffuse astrocytomas, they often grossly and on imaging will be quite demarcated, even though microscopically they certainly can have some invasion of adjacent tissue. The classic case has this biphasic appearance with loose microcystic areas alternating with dense compact areas. As you see here at higher mag, compact, loose. And in the compact areas is often where we find these Rosenthal fibers with elongate eosinophilic corkscrew-shaped structures and eosinophilic granular bodies, which are analogous but more mulberry-shaped. We tend to see most often in the loose component, as you see here. Anytime we see either EGBs or Rosenthal fibers, we always think this is a slow-growing, low-grade process, and that's very helpful. In the optic pathway, some of these turn out to be in NF1 patients and in the brainstem as well. But these actually can be stable over time, or they can even regress over time. In a small percentage of the cases where they're aggressive enough that patients lose vision completely, like in this case, they may do a resection or at least a biopsy. And unlike in other locations, these tend to be more infiltrative. So this is optic septi here with a bunch of tumor cells in the middle. It's not as obviously biphasic, and we may not see as many Rosenthal fibers or EGBs. But in a child in the optic pathway, the vast majority of these behave like pilocytic astrocytomas and molecularly are pilocytic astrocytomas. The other thing is that this is pilocytic astrocytoma is now considered a one-pathway disease, meaning that virtually all pilocytic astrocytomas have a mutation in something involving the MAP kinase pathway. The most common thing being a fusion and duplication involving the BRAF gene that we can detect with fish most commonly. And here's an example of that. So there's typically, here's the BRAF in red, the KIAA gene in green, and we look for both gain. So there's 3 copies in most of these, and fusion, a yellow signal of BRAF and KIAA. A variant of pilocytic is called pilomyxoid astrocytoma that virtually always occurs in infants, young infants, and by far the most common location is the hypothalamus, optic chiasm, anterior third ventricle. They tend to be more solid, less cystic, and on imaging, they're not biphasic, they're monomorphic, and typically have this loose myxoid background. So the cells look piloid, but you don't have Rosenthal fibers or eosinophilic granular bodies, and instead you often have these perivascular pseudorosette structures like you see in ependymoma. Now, these tend to be more aggressive than the average pilocytic, but at this point, the WHO has not assigned a grade, at least in this version of the WHO, because they felt more experience is needed with the pilomyxoid astrocytoma. Lastly is the pleomorphic xanthoastrocytoma, or PXA. And this is a tumor that, like this mother-in-law painting that I stole from my old mentor, Dr. Scheitauer, can look very ugly but not necessarily be highly malignant. And so these tumors, like the pilocytic and like ganglioglioma, often have a cyst with a mural nodule, enhancing nodule, as you see there, not always. They tend to be more superficial, and in younger patients, if there's a lot of the xantho or lipidized component, it can look very yellow, as in this gross appearance of a PXA. And there's often this disconnect between the marked pleomorphism that makes you think maybe this is a glioblastoma and the fact that you're having trouble finding mitoses. In addition, you have a lot of perivascular lymphocytes and EGBs. So again, here's the clue. EGBs usually means low grade. And the xantho part, you don't see it in every case, certainly, but it's basically lipidized astrocytes. They can be these large clear vacuoles or these small vesicular vacuoles, either way. These are the xantho astrocytes that you see in this. And they can also look very mesenchymal and form fascicles. So these are, unlike most other astrocytomas, they tend to be reticulin rich and GFAP positive, although they vary in how GFAP positive they are. And they can show some staining with neuronal markers, often in cells that don't particularly look like they're neurons. And so don't let that throw you off, just like with the oligodendroglioma. The German neuropathologists have identified that very frequently you have a lot of CD34 positivity in these tumors, either in the tumor cells themselves or in adjacent cortex, often where they have these spider-like ramified processes coming out of these cells. It's not absolutely specific, but very common in PXA, as well as in ganglioglioma and some forms of focal cortical dysplasia will have that as well. So the reason these are considered malignant, most of them are grade 2, is that about 15 to 20% of the cases will undergo further malignant transformation, and ironically, when they become malignant, they're much less pleomorphic. So this is the same case. The low-grade area looks like ordinary PXA. The high-grade area looks a lot like glioblastoma. So this is an area of anaplastic transformation, and the Ki67 is much higher, as you see there, and we have the BRAF mutation. And as I mentioned earlier, another rare type of anaplastic transformation is epithelioid, and basically resembles epithelioid glioblastoma. So I covered, I know, a huge amount of information. At this point, I will stop and ask people if they have any questions. Thank you very much.
Thank you, Dr. Perry. We have actually, as you know, that the lecture is broadcast live on YouTube as well as on Facebook. So we have a few questions, actually comments on YouTube first. So okay. I'm sorry for probably not pronouncing the name well. So there is Dr. Fikret Dirilenoglu. He is saying that he is happy to listen to Dr. Perry again after a long time. And so he was on YouTube. He
was here for several months.
Oh, yeah. I see. And there's someone else on YouTube also, so who didn't mention his name. So he also said that it's an honor to listen to your lecture, Dr. Perry.
Well, thank you very much.
So we have a question on Facebook. So actually, this is Dr. Balamurugan Tirunavukarasu. So he's from India at All India Institute of Medical Sciences, who is actually a postgraduate student who is working with Dr. Citra Sarkar, as you know her, I'm sure. Sure. So his question is, what is the morphologic criteria for diagnosing medulloblastoma with extensive nodularity, or MBEN? And he is also asking that is one low power field of nodular serpiginous area enough for a diagnosis?
Right. So that actually wasn't in my lecture, but I'm happy to answer that. But so that's, in my opinion, just an exaggerated form of desmoplastic nodular medulloblastoma, virtually always in infants. Often the imaging can be helpful because the nodules are so large that they look like a bunch of grapes on the imaging, so that can be very helpful. And it's basically extensive neuronal differentiation and a lot less of the primitive components. So unfortunately, the WHO, and none of the studies in the literature tell you how much you need for that. But I think it should predominate. You should have these very large nodules with extensive neurocytic and in some cases even ganglion cell differentiation, and relatively limited amounts of the primitive components. It overlaps greatly with the desmoplastic nodular subtype, and they're virtually always the sonic hedgehog molecular subtype, just like desmoplastic nodular is.
Thank you, Dr. Perry. I have a quick question. You talked about 1p19q co-deletion for diagnosis of oligoastrocytoma, that it is the defining thing for calling a tumor as oligo. So what happens in those places where they do not have facility for molecular testing and they just have a tumor which on morphology looks like oligodendroglioma? What should they diagnose these cases as?
Right, so that's an excellent question. And so the way the WHO got around that this time around is essentially if you have no molecular markers, then you're essentially practicing the WHO 2007 purely by morphology, and you should call that oligodendroglioma, NOS. So what that tells people is it looks like an oligodendroglioma, but molecular typing either wasn't done or in rare cases perhaps was not conclusive. Either way, it tells them that this is a diagnosis based only on the morphology and not on molecular criteria.
Right. So that similarly, suppose if we do the molecular and a 1p19q co-deletion is found to be negative, we also still call it oligodendroglioma NOS, or how do we call it then?
No, I would call it an astrocytoma in that case. So basically, with the molecular markers the way they are now, to some extent, astrocytoma is the default. But again, there have to be other markers, especially IDH. So if it's IDH mutant in particular and looks like an oligodendroglioma, but it's not 1p19q co-deleted, then you should probably call that astrocytoma IDH mutant.
Okay. Thank you, Dr. Perry. So we do not have any other questions. Anybody have a question? So thanks a lot. Thanks for sharing your time with us. It was a pleasure to have you with us, Dr. Perry. Thank you so much.
Thank you very much.
Thanks a lot.